Hello and welcome to the Confessions of a Random Doctor podcast. My name's Shovri. I'm a junior doctor who's basically just trying to find her way. Hello and welcome back to another episode. I've got the amazing Dr. Sabrina Kayani with me today.
Hello.
Who is my boss, kind of, my senior. And I'm really excited to have her to talk to us about what makes a good doctor, because she is definitely someone that I see as the epitome of being a good doctor, and she's definitely someone that I see as my role model that I want to be more like. So I'm really excited to find out more from her about what it is that she does that makes her so great. So thank you for being here, Sabrina.
That's okay, you're welcome. I don't know what to say. That's quite the intro.
No, honestly, it's like I said, one of the reasons why I really wanted to talk to you about this specifically is because of all of those things. And one of the reasons why I wanted to talk about it in general is because, like we were discussing the other day, I think when we think about what makes a good medical student, you know, we think about exams and assessments, and you have like a very objective mark that you get, which tells you how well you're doing. But we don't have that for a doctor. And so I'm quite intrigued to find out from your experiences what you feel would make those things.
No, it's true. It's true. So you're right in terms of what you learn in medical school. It's almost very difficult to implement day to day on the ward. I think even the shadowing period before you started F1 doesn't truly represent what you'd be doing, because almost, I don't know about you, but in that week I still felt very much like a medical student, because I was like, I'm just following this F1 round, I don't know what I'm doing. And then as soon as you were the F1, you kind of just have to hit the ground running. You're expected to grab the notes, or find the notes if you can find them, as the first task of the day.
That is the first task.
And then just run around after the registrar or the consultant scribbling. But I think it just comes with time, really. I was definitely very nervous when I first started, because I started in surgery, and the ward rounds go probably at about 100 miles per hour, and you're trying to grab all these folders, and there's all these patients that you don't know. A lot of the surgeons will expect you, or not even just surgeons, a lot of the consultants, the registrars will expect you to know all these little tiny details about the patient, because you're meant to be almost a constant on the ward, knowing these patients, whereas they're in and out either clinic, surgery, theatre, whatever they're doing. So in a way, that was like, it was baptism of fire, to say the least, because you don't know these patients. You've just started that week, but you just pick it up as you go along. But that is something I definitely did not know in medical school. No matter how many times I might have helped on ward rounds, I say helped very loosely, I didn't really do much besides pull the curtains shut. It's nothing like starting on your actual first day as the F1 on your own.
And so you've worked in quite a few different specialties, and you also worked through this pandemic. So how did you find that the working during the pandemic and working in these different specialties has changed how you feel about what makes a good doctor?
So if I go chronologically, it might help me make more sense in my mind. So that first Wednesday of August, when we were on our own, I started in neurology with general surgical on-calls. Thankfully, I didn't start on call. I just had a normal ward day. We were already fairly understaffed, which quote of the century, really, with NHS. So I was the only junior on the ward. I was like, I don't know what I'm doing. I've just got this whole urology ward. Thank goodness for the nurses. I tell you, nurses have been my lifesaver on more than one occasion. Make friends with the nurses. That is the number one rule. If the nurses are against you, the whole ward is against you, and you won't be able to get anything done. But my nurses were lovely, so that helped. And I think I was glad I had surgery first, because it prepped me to be really quick and learn about how to request scans and do different investigations. And we had such a fast turnover rate that you get so quick at doing discharge letters and TTOs and all these medications. You get on top of your VTE prophylaxis, you get on top of sepsis 6 for sure, because that's almost every day. So in that way, I suppose you're putting into practice what you learnt in medical school in terms of your knowledge, but in terms of the logistical side of things that I don't think medical school can ever prepare you for, you just have to learn every day. So on the first day, I'd be phoning switch I don't know how many times just to get through to x-ray, or in urology it was always ultrasound KUB, which was bane of my life trying to get that on the same day. I didn't realize how difficult it was to get I shouldn't complain really, because compared to pediatrics, which we're on now, getting ultrasound then was nothing. It was easy. Now it's even worse.
Oh gosh.
And you just pick up phrases that you've heard other doctors say. I think actually that's the way I learned. So what I'd do is I'd pay attention to the F2s. Well, we didn't really have F2s in surgery, the surgical trainees and the registrars, and I'd pick up good as well as bad habits. So the bad habits I would disregard completely, like I'm not going to listen to what this registrar is saying. But whereas the good ones, I'd be like, that's a good way of phrasing things, that's a good way of getting things done, or having that authority in your voice, which I didn't. I would initially always be like, oh, it's my first week, I'm the F1 on blah blah blah. Like I would emphasize the F1,
Yeah.
so they didn't have to ask me too many questions.
Yeah,
Because
sounds
I
like
knew
me.
I wouldn't know. But then I think you slowly grow out of that. So those 4 months in surgery, I still very much felt the imposter syndrome that you get anyway. I think up until the last day, I probably still didn't really know what I was doing in those first. I think it takes those first 4 months to figure out what sort of doctor you are. You learn to be organized. Organization is definitely key. You already know by us having to update the list every day. Because if the list isn't updated, you will have no idea what these patients have come in for and what needs doing. You definitely improve your handover skills in those first 4 months, because I think what we had a lot of twilight doctors in the night team, and we used to do handover to the junior team separately. So you'd learn how to do an appropriate handover, because those days that you didn't do a good handover at the start, not necessarily miss something, but wish you told something else, you wouldn't be able to sleep well, or the next day you realized, oh, maybe I should have said that. And you kind of learn from mistakes, thankfully not massive mistakes, but still little mistakes or little things that you wish you'd said, and then you remember it for next time. Or sometimes if you get a poor handover from another junior and you think, I know nothing about this patient, so you have to go and actually just learn about the patient from scratch, and then you realize, next time if I ever have to hand over this patient, this is what I'll say first. So it really is learning on the job. And then the first 4 months go so quickly, and then I think I ended up in elderly care beginning of December, which is one of the nicest teams. I mean, pediatrics has got a good team, but so does elderly care. They have one of the nicest teams. We have a lot of patients, but the ward I was on, they were lovely to me. The nursing team were lovely too. As soon as we started in December, it was already flu season, so COVID was not even in our mind. We weren't even thinking about COVID. I think we'd probably heard it on the news once or twice, that something's happening in China. We'd be like, oh, okay, but we've got all these patients with flu that we need to sort out. So all of them would get like Tamiflu, and we're like, prescribe Tamiflu. They didn't need as much respiratory support. It was more just a whole system involvement if they got really unwell. So we were focusing on that, and then it went into January, and then I think, was it maybe end of February, like, oh, what is this COVID thing that's happening now? Because you start to hear about it on the news. And I think, so in elderly care, I also did the general medical on-calls, and you'd hear about it in A&E when you'd go down to Clark patients, but it hadn't hit our hospital just yet. So you'd hear about it in London, you'd be thinking, oh, it's getting quite bad. And then I think it was probably, was it 3rd or 4th week of March, and I was on call that weekend, and suddenly I come back the next day for my on-call shift, and one whole part of A&E is just blocked off, and I was like, what is going on here? And they're like, we've had our first positive, and no one knew what they were doing. So there was all this information about PP, but every single person is doing it differently. Even compared to now, it was different. So you were allowed to wear the masks in the other parts of the hospital. You could only wear it in that part of A&E, and you had to change a mask for each separate patient. And we did not have visors then either. There were no visors. They kept saying you have to wear full PP, so FFP3, and then other people were like, no, you have to wear a surgical mask. And then other doctors were like, surgical mask with the visor, and I'm like, well, what is the rule? I don't know what the rule is anymore. So for that part of A&E, I think I stayed in there for my whole clerking shift, because anyone that came in with a temperature or a cough, which was everyone, because it was just nearing the end of winter anyway, all these elderly patients, either with cold-like symptoms or exacerbation of COPD, or just generally unwell, or being wheeled in. It was bizarre. It was a bizarre experience. I think I finished my on-calls thinking, I don't know what just happened. We've got our positive. I think the next day we had another positive, but I wasn't on call that day. I was off. And then when I came back to the ward, because I think they gave us the weekend off, and I came back on the ward, and suddenly, because we are elderly care ward, one whole bay was positive. I was like, what is going on here? And then we're like, okay, so this one bay is positive, so we have to be careful when we go in that ward, and the rest we treat as normal. And then you come back the next day and the whole ward is positive, and you're thinking, how is it going? And we still didn't fully understand exactly what was going on. So we were being sent in to swab all these patients, and we were all being sent in with different levels of PPE. There was no, we didn't even know who was exactly confirmed. They were all just high risk of having COVID.
Right.
So for ages we were waiting to get our first official positive on the ward. They were all just coughing or ill, which makes you think actually they probably all were coronavirus, but because the sensitivity of the test still isn't the best, particularly when doing it manually, perhaps we were just getting negatives, but they actually were all positive, because the way it spread from our ward to the next elderly care ward was the quickest I've ever seen. And then within the space of 2 weeks, our rota changed completely. So we were on the emergency COVID rota, where you'd have 4 long days. I already told you this, I think. 4 long days on, then you'd have 4 days off, and then 4 nights on, and then 4 days off, and then back on 4 long days.
Gosh.
And you're separated from your main ward team. So I was just with a random other elderly care doctors as well, which were all lovely, so it was fine. And then I was on the hot ward, so we were meant to have one hot ward, but I think in the end every ward ended up being a hot ward. And I didn't come back actually straight away, because I started getting symptoms
Oh
as soon as
yeah.
we started. So I got a sore throat thinking it was just tonsillitis, but then it developed into a cough, and they said stay home for 7 days, but we don't swab staff at the moment, so we don't know for sure. So your family has to stay for 14 days, you have to stay at home for 7 days, and then you can come back to work, etc., etc. I was like, fine. I still wasn't convinced it was anything. So then I went back after 7 days. It was fine. I was on the hot ward. By that point, both wards just had so many patients on 15 liters of oxygen and still desaturating, and I was like, oh goodness, what is this? And then my SHO was showing me all these x-rays with COVID changes, and you're thinking this is like nothing we've ever seen before. And I think each week it just kept getting worse and worse. And then there were times when we'd run out of oxygen, or when we run out of body bags, that's probably the worst. So I think at its peak, we had so many deaths in a day, it almost became the norm, which sounds very morbid and
Yeah.
very
Gosh.
depressing, which I guess it was.
Yeah.
But then you just had to do it. So it's hard, I think, but the one advantage of the pandemic was during that period, those few months, the hierarchy in the hospital was completely gone. You were all on the same level playing field. Consultants were doing night shifts. They were there for the whole night.
Gosh.
Two of them in elderly care. I think there were 2 in respiratory. Who knows how many of the ID consultants, the infectious diseases consultants, were in. I don't know. I think it was their moment.
Yeah.
It was mad. There was just so many of us in, and we all, I suppose, knew just about the same amount at the start in terms of managing this disease. And then obviously the more specialist you become, so the registrars and consultants, they had their own knowledge base that they could draw on and then pass the knowledge on to us. In terms of managing them, particularly in elderly care, I think it helped our communication skills more because of the unfortunate number of deaths.
Yeah.
So because of the number of deaths and the number of ill patients, every single doctor had to be called upon to have these difficult discussions, understand respect forms, understand how to fill them out, get the consultant registrar to then go through it with you. But you found yourself every day having these discussions, and they had to be over the
Gosh.
phone, which was the worst thing,
Oh
because you couldn't even
no.
do any of the face-to-face non-verbal communication. And I've told this to everyone, I don't think, if we didn't have that pandemic, I don't think I would have had the opportunity to have those discussions. I was lucky again because my SHOs at the time were so good that I could pick up on words I could hear them saying over the phone about breaking bad news, and then use them and tailor it to how I talk on the phone to relatives. Yeah, it was a mad time, Shah.
Oh
Strange times.
gosh. Gosh.
But then obviously we stuck on that rotation, so I didn't go to my next rotation, which was meant to be respiratory, although it pretty much ended up being respiratory, so I don't think I missed. Well, I must have missed out a bit, but the whole hospital had changed by that point.
Yeah, gosh. I don't think any of us could imagine what it's like, but I think you've painted a very vivid picture of just how difficult it was. One thing that I would really love to know from that is, how did seeing all of these doctors working in these different circumstances change what you regard to be important in being a good doctor?
I think watching all the doctors and how they communicate differently to patients made me realize how important empathy and communication is, because so many of us rely on face-to-face communication with patients and relatives. And whilst obviously with patients we still have the face-to-face aspect, although still limited because now we had masks and visors, so I think that was
Yeah.
actually significantly less compared to before. And with relatives there were barely any face-to-face interactions. That's a massive part of what we use in communication completely gone overnight. We had to stop all these visitors allowed in. The only time they were allowed in was in the last few hours of someone's life. And I think that probably improved everyone's communication. I don't think it hit us until it actually happened, how much we relied on face-to-face communication, but then having to almost be forced to use phone calls as a way of communicating with people. That must have helped improve our communication skills because we knew how to phrase things, because we couldn't obviously gauge how the other side would react over the phone. So we picked up cues just from certain things they'd say, or how often they'd phone during the day, or how they'd interact with the nursing staff. So it improved in that aspect.
Yeah, very true. So, from all of the stuff that you've done in the past year, would you say that what it takes to be a good F1 is different to what it takes to be a good doctor?
I think, like the name suggests, because F1 is foundation, being a good F1 or F2 leads to being a good doctor. So you need to have that good foundation. So you build up all these little skills, learn your own way of doing things that then you can then improve on and build on top of the expertise and knowledge and experience you then gain. So I think everything I learned as an F1 has improved how I do things now as an F2.
Mm-hmm.
And then that will hopefully improve with time. So each year, so everything you're learning now, Shah, will help you in your next job, and then will help you in your third job, and then help you with F2. If there is a third
Yay.
job, I don't know what's going to happen with the
Who knows what
rotations.
will happen, yeah.
Exactly. So I think, if you're a good F1 in terms of organization, you're building up good habits almost in terms of communicating with your team members. So you learn how to communicate with your team, learning how to communicate with patients, their families, learning the admin side of the hospital, which you don't learn as a medical student. You learn most as an F1, F2 because you're left to
Yeah.
do all the requesting for radiology, for bloods and whatnot. So you build up on that in F1. Then in F2, on top of that, I suppose you're improving in terms of your initial examination and assessment of all these sick patients. You become more confident in having difficult discussions. You become even more confident in all your organizational skills. And then as you specialize, then you can use this background foundation knowledge to then improve even further, because I think that foundation knowledge, that foundation skills will never go, will it?
Yeah, thank you. Yeah, that makes a lot of sense. So, one thing that I also wanted to find out from you is, do you think that there's a particular mindset that a junior or any doctor needs to be a good doctor?
I think so. I think you need to be very, very resilient right from the start, because being a junior doctor is hard work. Being any level of doctor is hard work, but particularly a junior doctor because you're on the shop floor all the time. So I think resilience is key, because if you're not resilient, then it's more and more difficult in the trickier situations, particularly when patients are very unwell. But that's also when your colleagues come into play. So use your colleagues to help, because you're all in the same situation. So if you're a good team member for your colleagues, then they'll also be a good team member to you. And then you can just go backwards and forwards, whether it's ranting or asking for advice. More often than not, ranting. But you kind of need to rant before you leave at whatever time your shift
Yeah.
finishes, because otherwise you take your work home with you, and it's not healthy for your well-being to have to keep thinking about it at home.
Yeah.
Yeah, no, resilience is definitely key.
And when you say resilience, what do you mean exactly?
So I think there's lots of different aspects to it. You'll come across different colleagues, they'll all act very differently and have different personalities. Some may come across as less kind than others, even if they don't mean it that way. So you have to be fairly thick skinned in this job. But that doesn't mean you should always accept what's being said. So you can challenge in an appropriate and professional way, or tell someone that you shouldn't behave like this, or that I feel upset by this comment. Even if it's with the person directly, or more often than not, it's better with your supervisor if you have those sort of discussions, because then they'll be able to point you in the direction that you should go into next from an outside view. Other way of being resilient, I suppose, just looking after yourself, because it's a hard job. You're doing these over 12-hour shifts when you're on call, and then you're in almost every day. You need to look after yourself, look after your health, look after your mental health, because only then can you actually be focused 24/7 whilst you're in hospital. And that's difficult to do, to always be switched on, because I think as a medical student you could zone out for a bit whilst you're just standing there,
Yeah.
and it didn't really matter too much because you weren't affecting this patient's outcome
Yeah.
in terms of their health. Whereas as an F1 or an F2 or whatever stage of training you're at, you have to be switched on all the time, and that is
Yeah.
tiring. It is tiring to be switched on all the time. You can't zone out for a bit because you're making little decisions that are going to affect how this patient is managed.
Yeah.
And I think at the start it is tiring. Those first few months as an F1, I was exhausted every
Yeah.
day going home. I was constantly thinking, should I have done this, or should I say this, or can I wait until tomorrow? Thankfully, I didn't get to the stage where I had to phone in to the hospital and be like, oh, I think I forgot this. I think what I usually did was I made sure I went through the list of every job that I had to do and ticked it off, and that made sure everything was covered. I think when I first started, even now probably, I still definitely have that personality where I'd let things get to me really
Yeah.
very quickly. I don't know why. I think that's just my personality, or maybe everyone does, and I just showed it more at that time. Actually, no, I think I'm quite good at hiding it as well. But then I'd rant about it afterwards. So my family are non-medical, so I'd rant in the car about something that's happened,
Yeah.
or about how someone has said something. So they'd be listening. They wouldn't really get all of it, but just having someone to listen to. Or I'd rant to other F1s and be like, yes, this happened to me as well. I think that helped the most.
Yeah.
Definitely use your colleagues. I think we've got a good team now.
Yeah.
I've been lucky that every team I've worked has been good. I hear horror stories of other F1s or F2s that haven't had a good team, and it affects that 4-month placement
Yeah.
massively. You become you are close to burnout if you don't have a good team, I reckon. I can't stress enough how the importance of being a good team member.
So we've spoken a little bit about some mindsets that you think are important, about some
hmm
skills and traits that are also important, and some general advice that would help in the day-to-day job. So how can someone self-assess that they're kind of meeting these criteria or they're doing these things?
Is actually very difficult to self-assess. I think I still struggle with that now.
Yeah.
I only hear it from others when they say, "Oh, you're doing a good job," blah blah blah, and I was like, "Oh, that's nice." But is there anything specific I
Yeah.
should be focusing on?
Yeah.
So you kind of have to just ask regularly throughout your shift. So a lot of the SHOs or consultants or registrars that I want to be like are the ones that would provide me with feedback without being prompted. But if you're, for example, if you're on a long shift with someone that isn't giving you feedback, they're good to work with, but they aren't giving you specific feedback, and then just ask. I would just ask, like, how did I do today? Or after presenting a case, was there anything I should have done differently? I say that a lot. Was there anything you would have done differently? Or was there anything I should have thought about? And then they'd let you know. And in that way, I suppose you kind of learn from the medical point of view things you should have thought about, but also how to phrase certain things, or to consider other things. I think that's best, but you definitely have to ask. Other things you already know with our e-portfolios, we have all these tabs and everything and mini kexes. The ones that take their time to fill that out, they give the best constructive feedback. You be able to read all that obviously once they send it back to you, so that helps. Other ways, now you shouldn't compare yourself with other foundation doctors, but asking for their experiences is still a good learning opportunity, because you can find out how they managed a similar patient.
Yeah.
They might have done something that you didn't think about. Yeah, I think that's about it. You pick up little cues of people saying, oh, you did this well, or you should have done this, rather than just pass it off as a random comment. Ask them to be more specific. They won't mind because they're thinking it. They shouldn't say it out loud if they don't want to say it.
True.
um,
Yeah.
and just say, what do you mean exactly, so I don't forget for next time, or
Yeah.
how to improve for next time. And don't take it as like a criticism, unless they're saying it in a bit of a strange way. If they're saying it in a rude way, then that's criticism.
Yeah.
But if they're trying to be helpful, then just ask them to be more specific, and I think then you'd learn. I think a lot of the times you learn from make your own little mistakes, like I said before.
Yeah.
And then if you have the discussion with a senior, with a supervisor, if you get along with your supervisor, or a registrar or a SHO that you're close with, then you learn from that. I think I know what our department's trying to do is that debrief, is that cold and hot
Oh
debrief.
yeah.
So after a specific incident has happened, it doesn't even have to be a very significant incident, they lead a debrief. I didn't join the one recently, but they did one recently about a patient case, and they go through all different aspects about it, medically in terms of what should have been done differently or what was good. But also, I think they touch base with how the doctors are feeling,
Yeah.
so how they felt about it, which I think is good. And I think it should be part of every specialty, every department,
Yeah.
that regularly you should leave these debriefs or have a room where in confidence you can explore these different worries. We don't do it enough, and it's a bit more difficult now, obviously, with this pandemic to do it, but I think it's still even more important because you're going to come across situations where you're not as comfortable anymore. And because we're in unprecedented times, I don't know how many times we've heard that
Yeah.
phrase, but it's unprecedented times. So I think, yeah, it's important to have those discussions openly. Just be open, don't keep things bottled up, because that will make it harder.
Yeah, for sure. And like you mentioned, it's also the fact that, you know, we're in isolation, so we're not interacting with as many people. So you may not be able to come home and rant to the person that you used to rant to. And so
Mm-hmm.
you might feel a lot more reliant on your colleagues to provide that support.
No, exactly. I think I felt lucky that thankfully I didn't have to move out and I came back home to my family that I could rant to. But I know friends that did have to move out or friends that lived alone. And I just be like, phone me anytime. We can rant whenever.
Yeah.
Or I would, if it's a colleague at work, just rant before you leave. You need, it doesn't matter how long it takes, just rant on that day. Don't leave it to rant another day, because then you'll just, I don't know, I think it's just too tiring otherwise.
Yeah, for sure. And so, have you got any advice for new doctors who are listening to this who feel like they're not quite sure if they're doing a good enough job, or they don't know how to check that they're making an impact with their day to day work?
Firstly, you are all doing a good enough job. I think if there were any problems, you would already know. The fact that you're wondering, am I doing a good enough job, usually means that you are, which I say to you, I think, on a daily basis, Shah, because I know you're doing a good enough. You're doing more than a good
Thanks.
enough job every single day. So this imposter syndrome you will have for a long time. It will keep coming and going, but I think it will just become less frequent as you become more experienced. In terms of checking or finding out whether you are helping or making an impact, again, outside of just talking to your colleagues and your supervisors, go home and think about that patient case that you're worried about, and think about it soon after it happened, but then also a few weeks down the line, it'll probably pop in your mind as well. And what you need to do when you think about a case is kind of remove the emotion from it, because if you were particularly affected by the case in terms of it made you so anxious that you forgot something, or it made you so worried that you didn't do so well in it, think about it objectively, like it's a patient, like a case presentation. How would you go about it if you were going to see that patient again from the start? So that's helped me on a number of incidents when, if I did something for a patient and that was fine, but then a senior would say, oh, you could have done this, this, and this.
Yeah.
Or why didn't you do this? Or you missed this out completely. It's so important, because if we'd missed this out completely, it would have had a detrimental effect, I don't know, tomorrow or the day after.
Yeah.
And then in that moment, you're so shocked. You're thinking, oh my goodness, I could have caused harm. And then when you go home, you need to get over those emotions first, whether that's by ranting or, I don't know, whatever you do to calm yourself down. And then think about it as if you were an outsider looking
Okay.
in. Think about that case. Think about what would you do differently. And then more often than not, you'll remember to do it next time, or you'll do it differently next time, and you'd improve on yourself. So it's a lot of self improvement. I think you're reflecting on what you've done yourself.
Yeah.
And I think if you become good at improving yourself, just constant reflection, you don't have to write it out
Yeah.
all the time. If you do it, little mini reflections in your head about your work and how you've done, you'll find that you are improving week on week, month on month. I know that F1s that are starting out, if you look at yourself at the end of your second rotation compared to what you're like now, you will be shocked by how much you've changed, which seems like a long time away,
Yeah.
but you will definitely have noticed how much you changed. Even now, so when I first started F2, I kept forgetting that I was an F2. But then I was thinking back to being an F1, I was thinking, oh my goodness, why was I worried about all these little things? Or how could I have done such a silly little thing? But I think that's also similar in medical school, isn't it? So when you start clinical placements, you never think you'd be able to do clinical
Yeah.
placements, but you do. And I think that's just the nature of just human life.
Yeah.
If I could get any deeper.
Yeah, no, that's so
I
true.
think it's just, yeah.
I still remember, when you're a medical student and you move up a year and you're kind of still introducing yourself with the previous designation.
Mm-hmm.
And you're like, hi, I'm a third year. Oh no, sorry, I'm a fourth year
Yeah.
medical student now.
Yeah, even now, the number of times on the phone, I'm like, oh, my SHO wants to talk to you.
Yeah.
And I think, hang on, I am the SHO. Who wants to talk to you? I don't know.
Yeah, exactly. Yeah. So, do you have any sort of resources that you would direct people to, or quotes that you found to be particularly memorable surrounding this topic of self improvement and self reflection?
That's a good question. I can't even think of anything. I think a lot of the time, what I'd find myself doing was watch like YouTube vlogs
Mm,
of junior doctors.
okay.
I don't know why, because then you'd find them in a similar situation to you.
Mm-hmm.
Those sort of things. I don't think I actively searched out for any resources. I know our trust has a well-being hub, which I never got to go to, which doesn't sound
Aw.
great, but I've heard it was very good.
Okay.
I was always just very busy,
Yeah.
which is probably when I should have gone.
Yeah. Sounds like if you need to go there, then you can't get there.
You should have, yeah, exactly. They had a list of resources that you could go to. I was just very lucky that my clinical and educational supervisors were with me on the
Oh
ward all the
yeah,
time.
that's really good.
And they would constantly check up on me. So they'd be like, everything okay?
Yeah.
How are you managing? Even if I was fine that day, or even if I wasn't fine, they'd still ask me.
Yeah.
And I think if you're like that for your juniors, you will eventually have juniors, Shah, don't worry. Then I think that's a good trait to have going forward.
Yeah.
You need to learn for yourself when things are getting too much. And I think if things are getting too much, then use an outlet, whether that's your friends, family, writing stuff down, or just doing something completely different. Because if you recognize it early on, then at least that'll help you in the long run.
Yeah.
The number of times I'd write stuff down and then just to get it off my mind, and then you can throw it away, it's fine.
That's a good idea,
I
actually.
did a lot of ranting. I do a lot of ranting anyway. Even if I don't mean half the things I say, it's just helpful to get it off.
Yeah,
I think we do a lot of rant. We do rant a lot.
we do.
I think we rant after ward round. We rant at
We
lunchtime.
run during
We
the
rant.
jobs.
We rant during the job. We rant whilst we're doing that specific job,
Yeah.
even though we've done it.
Oh my
I think,
gosh.
yeah, I think that helps a lot. I think just venting to someone helps a lot.
Yeah, I'm very glad to have a team that includes you in it for sure.
Oh, thank you, Shah. I'm glad to have you there as well.
Oh, thank you. I'm so, so thankful that you came and spoke to us about all of this. Overall, this has been so, so useful. Thank you so, so much for coming and talking to us. I think I've definitely learned a lot about the power of self reflection, ranting, and also the power of the team around you and how important communication is for sure.
Communication with patients or between colleagues, whatever it is key, I think, in our job.